אנחנו מתחילים. שוקי. צהריים טובים. אני רוצה לתת הסבר קצר מה אנחנו הולכים לעשות. אנחנו בכנס נשענים על שני יסודות.
We are basing this conference on two pillars. National security, Iran, etc., and our national resilience. As far as I'm considered, the national resilience is like termites that are eating us up from within. The health system is a foundation of our life. It is a strategic essence here. And so I was very happy to find out that we were able to cooperate with the Assuta staff led by Professor Shuki Shemer. I know Shuki for many, many years. He is a combination of a doctor, a leader. I remember when I was the IDF spokesperson, when he was the IDF spokesperson, he cared about each and every one of the soldiers. And together with him, under his guidance, we have gathered an exceptional team of speakers. And they did wonderful work, and we have the best of people here who are part and parcel of the leadership of the entire Israeli health system. The questions are quite difficult. Do we want a health system? I have a personal conclusion, which is no, we don't. They say, for example, 5,000 died of infections. Who cares? But if one died because of a terrorist attack, we see headlines for 5 days going. So I have my conclusions, but I'm not going to share them all right now with you. And I'm very, very happy. I don't want to say ecstatic, but I'm very happy to have had this cooperation. We're going to have a panel of speakers. We're going to have a work group that will prepare a work paper. And we also have the very senior journalist, Shimon Shiffer, who is going to appear here not under his strategic commentaries, but rather a personal story. Professor Yossi Weiss, our partner, and we are his senior partners. The floor is yours. Thank you very much, Major General Amos Gilad. Amos, I'm saying thank you. I'm thanking you once for incorporating this topic of health and the health system in this important conference, which is dedicated for strategic matters. And the second thank you is for everything that I have learned from you in our meetings, and we had quite a few preliminary meetings, and for the fascinating analysis of the surroundings close and far, and the third time for your exceptional cooperation through and through. I salute you, the organizers, for the fact that this year the issue of health is a prominent topic here at the conference. Distinguished guests, ladies and gentlemen, out of the ruins, understanding came about. Out of pain, the cure arrived. In December 1948, the General Assembly of the United Nations adopts the declaration for all people of the world regarding rights of a person and civilian. Humanity proved that it can really kill quite well each and every person. The root of this declaration stems from one of the lowest periods of time in the history of humanity, the Second World War, the Holocaust. In this framework, there was a recognition in Article 25, the right for health. And when we say it is all about health, I put a question mark there. Is that so? When we are healthy, when we have our health, we don't think about it, and we feel that there is no limitation to our capabilities. But when we are lacking it, our weakness is out there for everyone to see. We have a fascinating session all about health It is in the midst of the conference, and it includes several dimensions. The first one, the remarks of Professor Shemer, who is going to talk about the contribution of the health system to the national resilience, the personal resilience. This will be followed by Mr. Moshe Siman, Director General of the Health Ministry, about things that are planned, things that need to be done. And then Mr. Shimon Shiffer will share a personal story. After that, we will have a panel with key people that will tackle the question, what is the role of the health system in the overall considerations? Or did Israel decide to let go of the health system when it is now at the age of 71? Being very honest, and I'd like several seconds here, is a central health system dear to our hearts. I have the privilege and the honor to present Professor Shuki Shemer, the person who experienced more than anybody else health systems in Israel. Professor Shemer is a professor at Tel Aviv University. He is a specialist of internal medicine. He finished his role as chief medical officer in the IDF. He was director general of Maccabi, HMO, and now he's leading the Assuta medical centers. He built the first hospital of the Maccabi group at Ashdod, and he chaired the medical basket, the committee at the Ministry of Health. Professor Shemer, the floor is yours. Hello, and thank you, Professor Weiss. This is time to retire with dignity after such a great introduction. And you know that one of the recommendations is when you speak at the hall is to make sure that you have a very nice atmosphere. So I'm very happy to see Ron Prof here, and I guess he's doing diplomacy and health together, and also Ofra Strauss, who is working nights and days, and I'm always talking to her about how to better the quality of food, so we have high quality food. Saar, who is the CEO of Leumit HMO, Meuhedet HMO. We're talking about national resilience, so this is it. And other friends who are also present here, the Director General of the Ministry of Health, my friend. Okay, so now, in order to create for myself a comfortable atmosphere meeting you, I'd like to pose two questions. The first being, how many people here don't have any occupational contact or work with the health system, so I'll know? Just raise your hand, please. Okay, I think about 1/3 of people. How many belong to the health system here in the crowd? About 2/3. Perhaps the second question. I think that we have a strong health system. And I think that we have the best doctors in the world, and I think we have the best nurses and medical teams in the world. But then I'd like to ask the following question. Is the health system in Israel a good system? There is a difference between strong and a good one, because it is all a result. It was not planned ahead, except of the hospital in Ashdod. There was no real plan for the health system. How many of you think that there is a good health system in Israel? Raise your hands. About 1/5. I guess some don't have a view. How many think that it's not good? The majority. I wish the Director General of the Ministry of Health would look back, and I'll tell you why you think that, like that. Well then, I want to put in the center of our discussion the issue of empathy. I'll say that again and again and again. There is no consideration, there is no discussion. Doesn't matter if it's budget or otherwise, they don't talk about compassion. Compassion is identifying with the person suffering, and this is our role. And when we look at the various people in the hospital, in the courts, maybe it's very efficient. According to the OECD, we are very efficient. But are we compassionate? And I'll share a story with you. Some people probably heard the story, and I apologize if I'm repeating it. A student told me, and Amos, of course, I'd like to thank you for what you have said. These are things that we also dealt with the military. a student, a medical student. He was a resident in one of the hospitals in Israel, that he had to examine a 68-year-old woman in the corridor right next to the toilets. Now, when there is a patient there, 68 years old, it's not a bag of potatoes that was just thrown out there. Think about the closest person to you, your mother, your grandmother, your uncle, aunt, a person who's very dear to your heart, and then he goes to the nurse and asks for a screen. But the nurse says, sorry, we don't have a screen. And he is a student, 6-year student, and I hope that he's not going to act differently in the future. It is a real story. So he stands by this lady, a distinguished lady. Maybe she has her own history, maybe she's a newcomer, maybe she's one of the founders of Israel. It doesn't matter. It's a person with a past, a present, and hopefully a future. And he says, Madam, I'm going to look for a screen because I need to examine you. And what does she reply now? Close your eyes and think about what she just answered. She says, Doctor, it's not necessary. I'm used to the doctor examining me and taking off my clothes in front of everybody else. So what does she really say? I'm humiliated. I'm already accustomed to this humiliation. This is maybe the 20th time I'm telling this story, and I'm still struck by it. It reminds me of stories in the history of people that I don't want to talk about right now. The question is this the right way to go about it? And our hospitals, as a result of this, we heard about the Iranian nuclear bomb and the casualties each and every year. And you can ask the Ministry of Health, the Director General, about 4,000 to 6,000 Israelis die of infections that should not have been there. People do die, there are infections, but from unnecessary conditions. And the question is, should we make do with this? Should we agree to this situation? Moreover, do we have anybody here from Be'er-Sheva? Anybody from Ashdod here in the crowd? We do. There are gaps of morbidity in the various areas of Israel. Life expectancy of the people from Be'er-Sheva is 4 years lower than residents of Kfar Saba. Kfar Saba, you get 4 more years. In Ashdod, they live 2 years less than the central areas of Israel, also in Bat Yam. So the periphery is not only geographically a periphery, but it's also a periphery for receiving health services. The question is, should we be okay with that? And I'm putting this in the center of our discussion. This is this national resilience we're talking about. Is health part of national resilience? This is something I want to put out there, something I have been talking about recently, just as I have been talking about this old lady in the corridor of the hospital. I've been meeting ministers and heads of state, prime ministers. I think it's a criminal offense to have a person lie in the corridor of a hospital. What does it do to our national resilience? And of course, it costs money. Everything costs money. How are we going to strengthen our national resilience? Through the health system. So, national resilience, this is a definition that relates to the strength and the resilience of society in various areas. The ability to withstand a threat, a given threat, but not only at times of emergency, also at times of routine, and of course the ability to recuperate after a crisis. Maybe the Director General of the Ministry of Health will talk about it, but later I've been reading in the press that there is a doubt whether the health system currently can handle emergency situations with a large number of people that are hurt, etc. I've been dealing with it for dozens of years, and I was certain that the health system can withstand it. And we have Professor Arnon Afek, who is formerly Director General of the Ministry. He also dealt with this. When I'm reading something like that in the newspaper, it undermines my own personal security. Is that so? and we have so many threats around us. There are all sorts of types of resilience. We have national resilience and community resilience and private resilience or personal resilience. And of course, in this jigsaw puzzle, you cannot only have health stand independently. And of course, the Director General would say, yes, there are other needs, and I understand them. We all as citizens understand that there are needs for security, economy, education, of course, transportation, aviation, and we heard about a lot. What are we doing to the national or the social resilience in Eilat? But I deal with the health systems, and I'd like to relate to that coming from my own personal experience and knowledge. So when we talk about the personal, private resilience, it means how does a person perceive themselves, their health resilience, their mental resilience, and this is affected by the level of services. And community, well, this has different characteristics. How does the crowd in certain areas like the Golan Heights, going to Bat Yam and other areas in Israel, what do they feel about their health situation? How does a healthy society contribute to the entire resilience of the Israeli society? How do we map the needs on a daily level and also in disaster times? And it doesn't have to be war necessarily. We are hearing discussions about an earthquake. As far as I understand, according to what I know, the state of Israel cannot deal with casualties as a result of a very harsh event of an earthquake. And the health systems is the key for this resilience. And when you look at the entire national resilience, it is an integral where the general private resilience and the community resilience, it relates to the resilience of society and its power. And then I can talk about all sorts of threats, whether it's biological, chemical, war, missiles of this or other sort. What are the components of health as national resilience? On a daily basis is providing an answer for the weak populations. If we cannot provide a proper answer for the elderly at every age. Sometimes I envy the Eskimo. There is this urban legend where they would send their elderly to die out there in the snow. A society that doesn't know how to handle mentally ill people. It's better that you don't be part and parcel of such a society, but they have families, these people, and this is a real sickness. A society where, and Ben-Gurion said there's never going to be a full equality, but striving towards equality must be a national value. If we don't do enough about health, if there aren't enough efforts to bring an equality between peripheral areas, and it's not only geography, between the various parts, and I'm not talking about people who have wealth and private medical treatments. I hope that we'll reach a day where we don't need to have private insurances, and people who have connections will not need to operate on that. Policymakers never, and of course, everything has to do with the level and quality of the health systems. The result is the improvement of the outcome. So what are, well, all in all, we have a good model. We have a very good health law, one of the better ones world round, but it's not being held up to, meaning the continuum of the model, executing the model, and we lack manpower. It is not available. Some of it is not trained enough. It cannot fully express itself, and we lack on information and supervision. It's not as if we don't deal with it, but the outcomes shows that we are lacking a lot, access to medical equipment. So they double the number of MRIs, and then the lines grow even bigger. People want MRI, PET CT or CT right now, and if you call the various centers right now, you'll see that you have to really wait for a long time. And PET CT should find cancerous areas, and when there is a month delay, you have to understand what it means. The implication is closer death sentence, so to speak, waiting in line. This is not a nice to have. I want an appointment. Well, you go and get it now or in a month's time. But if you have a lung cancer and they have to wait for a month, they are shortening their lives by several years, and this is a proven thing. So the entire issue of equipment and technology that have to should be expressed, it needs to be covered, it needs to be managed. So we went for a survey. We wanted to see what the public at large thinks. And national resilience, this is a term that I coined, and I see that it's being used in the newspapers, also in the Haaretz, for example. It's great that health is being discussed as national resilience. Someone should refer to it, and not just prior to elections, because then all the hospitals get budgets and everything. Nobody understands what does it mean to establish a hospital and build one in Israel. Only Maccabi, who built the hospital in Ashdod, know exactly what does it mean to build a hospital in Israel. And listen to what I'm saying right now. We're not going to have another new hospital before 10 or 15 years elapse. That's the worst case, because a hospital is not only building the structure and the facility. You need manpower, you need simulations. It's a whole story to itself. So we had a combined survey, online and phone survey with PharmaQuest company. We went through a demographic characterization. The first question was, an intuitive answer was required. When you hear national resilience, what comes to mind? So the first thing that's obvious is security. At that time, there was a political party that was called Resilience, so they immediately thought about it. What was surprising to see is that only 3% viewed health as part of national resilience. It was surprising. It was also bothering because this idea of national resilience is not part of what people think about it. Maybe if you only put national resilience as a currency, so that next time we hold a survey, when we ask them what is national resilience, they'll understand that it's also health. On the health system. The next question, what do you think characterizes a personal resilience? Of course, it's financial stability or overcoming difficulties, but health only received 12%. 21% were given to economic resilience, and the rest of things are also important, but you have to see if national resilience is part of our consciousness and awareness, and I guess not, because it's not part of our leaders' understanding. There's a difference if you talk about money and investing and building and doing, when these are not really happening or can never materialize. How does the public in Israel evaluate their personal and health resilience? Here, the green column is a low score, and the blue one is a high score. So if you compare between your personal resilience on the right-hand side and health, the other column, people perceive themselves as their personal resilience being higher than the entire health resilience of the population in Israel. It's very interesting. I'm healthy, I'm tall, and blonde, blue eyes. I'll never be sick, but the other people out there, their situation is not so good, because I'm hearing stories all around. How does the public view various aspects relating to resilience? So there are several statements. Ultimately, 80% believe that we need national resilience at times of routine, not only at times of crisis, and 70% maintain that the health system is contributing to the national resilience and the social resilience of the State of Israel. The ministries of the government needs to be aware of that. And when people were asked regarding national resilience, does it have to do with the security of the State of Israel? 50% or 49% think that this is not only related to the resilience of Israel. Amos, you talk about issues of security, but also about health and medicine. This is a topic unto itself. We asked the question, in which of those areas should the state invest? Most people talked about education. I definitely accept that. If I had to put my last shekel, I would do it in education, security, health, welfare, etc. But when you ask those very same people who put this in the first place, and now what would you invest in? 58% say they would invest in health. So they do see health as a component of national resilience. This is something that should be taken into account. Now, talking about the percentage of budget that should be allocated to each and every area, I agree. Leading is security and then education. They are quite similar, and also other areas, but they also view health as quite up there. Third place. I'll give you an example for opening the Ashdod hospital. Ashdod is a city of 250,000 residents, the fifth in size in Israel, one of the 10 cities that did not have a hospital. Socioeconomically, the population is not so great. Missiles attacks occur. And 1 year after the hospital was opened, we asked, do you think that the new Assuta Ashdod hospital is going to contribute to the city and residents? 38% said 93% said yes. And when we ask the question, some would say it's close, obviously it's very convenient, but it allows a sense of ease, a sense of security. This is interesting. I'm not talking about the image of the city and change for the better for the entire city. So what are the insights from this survey? Health is rated third in contribution to resilience and the will to invest. The health system is contributing to national resilience. Within the health system, there is a willingness for financial investment for the medicine basket. We have the broadest one in the world. I was heading this committee. I was there for 10 years' time. We had the broadest pharmaceutical basket in the world, but still the public thinks that we need to invest more finances there. The question is, where should we invest more? Should we have expanded all sorts of medicine that we don't know exactly if they're helping or not? And my conclusion is that health increases national resilience and personal resilience on a day-to-day basis. So what needs to be done? I think that on the level of declaration, we have to recognize that the health system is a necessary component in national resilience. I think that if I would have held a vote right now, most people would think like me. The strength of a state is dependent on the personal, social, and national resilience, and the health system is a necessary component. And so I think we need to increase the investment by 10 billion shekels. It is a national investment. I'm not talking about the first year. We can spread it along several years, but the basis is 10 billion. Everything that I'm stating here is my own personal opinion. I did not talk to anybody about that. The third thing is to have a national hospitalization authority in order to deal with all areas. When I was Director General of the Ministry, I prepared a plan of that sort, but it didn't came to fruition. And I think it needs to incorporate all hospitals, private, public, also the Assuta hospital. Each one would preserve their own corporate structure. And this is in order to have an open discussion that doesn't happen nowadays, and also resolve the clash of interest where the Ministry of Health and its Director General is always in the midst of. I never know if I'm responsible for the general hospitals or the private one. One needs integrity. The General Director is going to follow me. He's at a conflict of interest, despite the fact that he built a department of state hospitals. And this is the basis of everything that's wrong about it in Israel. And we also need a national authority of hospitalization. This will improve on the working of the hospitals. It should decide upon opening very expensive wards in the same geographical areas. It should prevent the opening of unnecessary wards, not according to the director of the hospital or even political decision, which is not as not of the general interest. Just like the electrical authority sets the prices for electricity, it should also set prices for hospitalization and monitor and control it. Now several words about the allocation of resources. So we talked about increasing national investments. We have to train manpower. Training a doctor takes 15 years. Training nurses is 7 or 8 years. Rationalize the pricing, because the pricing of hospitalization amongst the hospitals and HMOs are unrealistic. They don't cover the input of the hospital. All hospitals are at a deficit. This is a negative incentive for the streamlining of the system. Talking about streamlining, I think that providing public services should be by private suppliers. The private system is more flexible and more efficient. It's not because people are better, but it has flexibility of management, and it must be an infrastructure for the public services. We have to consider deploying services in Israel throughout, from the north going to the south, and I'm very familiar with all sorts of entities that would like to do it. Assuta is one of them, so that ultimately the system will cover what it needs to do, providing health services throughout Israel. And now, the burden that we see at hospitals is going to be resolved by all sorts of positions that will be added. We don't see those patients that are staying for no necessary reason at the ward and the ER, they stay there for 10, 20, and 40 hours. And I know, at least for my own family, that these numbers are real numbers, and I go through ERs. And the last topic is that of the home hospitalization. I think it's a very efficient solution to decrease the number of patients, and we have to implement regulations so that at every point in time we're going to have 1,000 home hospitalization. It's going to be more efficient for the patients, more humane, better medical care, and will prevent all sorts of unnecessary infections. This should be done, according to my opinion, of course. And the responsibility should be together with hospitals and HMOs. While there is a manager of the ward and nurses alongside, it has to work not only in giving medical care at home. Maybe the Maccabi director will talk about it, how they do it in the north and the south. It has to be operative 24/7. It has to provide a holistic, integrative treatment throughout time. And this will provide dignity for people. Now, ultimately, last sentence, this harsh reality right now, we see that compassion is lost on us. I started and I opened by talking about compassion. Shimon Shiffer is going to relate of his own personal experience. The health system needs compassion. I would call it the Ministry of Health and Compassion. And compassion must be taught. It must be taught all the time, not only students of medicine, but also nurses, cleaning personnel. Everyone who's part of this system has to know what is compassion. It is identifying with the person suffering, so that we can prevent this icon, this story, this issue of this old patient lying in the corridor. We all agree with that. We all make do with it until it comes close to home. And ultimately, everything, all of these things that I mentioned, they must be all enveloped by this wrapping, soft wrapping of compassion once again. Thank you very much.
Thank you to Professor Shemer, and now I have the honor of calling upon the person who has the overall vision, who every morning gets up and is responsible for the entire health system in Israel, the Director General of the Health Ministry, Mr. Moshe Bar Simantov. Good day to everyone. I'm happy to be here. I've been at a number of conferences of the Herzliya conference, and the subject of health was never discussed in the main plenary. So congratulations to the IDC and to the conference and to Major General Giora Amos Gilad. And indeed, just a moment, please. The ability to improve the health system depends first and foremost on the public discourse on the health system and the understanding that health is a vital component of national resilience. There can be no national or social resilience without a proper health system that functions properly, and you can't win wars without a functional health system, and a health system cannot function in emergency times if it does not function in normal times. I will say a lot of things that may not sound optimistic, but ultimately I am optimistic because I believe things can be changed. I saw how close we were before the previous Knesset dispersed itself, and we met with the Treasury, and we were just about to close on a significant program, and then the next day the Knesset was disturbed. I'm happy to see that the many people are joining the discourse on health here at this conference. Mostly the subject is medical cannabis, but we see other subjects as well. Let's see what's going to happen in the coming decade. Perhaps our greatest problem in the health system is that in relative terms it works very well, but what happened in the past isn't going to necessarily happen in the future. Shuki spoke about the past, but the coming decade is going to be something entirely different, and the intensity of what will impact the system are going to be on a much greater scale. There are things that happened, but are happening much more intensely now. Unhealthy lifestyles, now we're seeing much more chronic morbidity, more people who are going ill at younger ages. We see the population aging, and the lifespan is growing, and the number of the elderly is growing, and in the coming decade the number of elderly people 75 and more. I know there are a lot of young people here among the audience, but let's take those who are 75 and over. This number is going to double itself in the coming decade. This is unprecedented. We like to think of ourselves as a young country, and this is changing. And another thing is that the public tolerance for poor health systems is decreasing. If people in the past were willing, despite what Shuki told about the intern and the screen, if people were willing to wait in the ER and in the hallway and so on, they're no longer willing to do so. The public is waking up. It causes a lot of criticism, but we consider this a blessing. And let's see what happened. This is a slide that whenever we show it, it never works, but we prepare it ahead of time. Here we see the pyramid of ages in the state of Israel. There are, like all pyramids, there are a few fewer young people and more young people and fewer old people. And Shuki talked about how long it takes to train a doctor and a nurse. We're seeing the pyramid distort, and this is what it will look like, and it will continue to, and it will, this is what it's going to look like. It's almost an anomaly. We had a Holocaust, and we had a rebirth, and we had Aliyah from the former Soviet Union, and these people are starting to leave the work market, the job market. They are elderly, and this is very, very significant in terms of the health system. So a little bit about the system. You'll hear a lot of numbers here, and you'll be told that the government is investing a great deal of money in health, and it is, but there is something that hasn't changed for many years, and that is the percentage of the national expenditure on health, 7.5% stable and insufficient, and it is far lower than in other developed countries, between 8.5% and 9%. We won't talk about the U.S. and it's 18%. That's almost an anecdote in macro terms, but we are still behind. Another interesting figure is the ratio between the public and private. In all the developed countries, there is a private health system alongside the public system. The government is not expected in any country to pay for everything, and that the public will not put their hands into their pocket for health. The golden rule, the maximum that can be obtained, that the World Health and the OECD talk about, is 70-30. There are countries, the Nordic countries, there are 80% public and 20% private. And here the ratio, after a great deal of work in recent years to improve the ratio from the time of Professor Ronnie Gamzo, we improved from 60-61 to 63. I've rounded out the numbers. It's actually 62.8. So there is a much greater burden on the citizens from the point of departure, less public expenditure, more private expenditure, and less on the national level. We talked about the aging population. What does this number mean? It's not just a number. It means that an elderly person, their demographic weight is greater than a younger person. It can be 3 times more and even more than that. And this gap seems an addition of 0.5% of the population each year. In Israel, there's another thing that is unusual in the developed countries. We are a growing country. Our population is growing. Our population grows by 2% every year. This is unprecedented in any other country. We are 9 million. By the end of the decade, we will be 11.5%. But we're also growing older, and we have this gap, which is almost 500,000 people who are not budgeted. In other words, people are coming to the state, and we cannot give them full coverage, and that is one of the points that we will have to contend with. And another thing that is happening that makes everything almost perfect storm is that costs are rising dramatically. This is a figure that we took out yesterday. A new oncological drug that entered the basket 10 years ago would cost a few 34,000 shekels in 2000. Now the new drugs are now on an average of 250,000 shekels, and we are very, very far from the last word being said. A drug that owes 1 million shekels a year, this is not unusual anymore. And then we're seeing in the past patients that had drugs that cost 1 million or 2 million shekels a year. There was a handful of patients, and now we're seeing double digits in that. And we have the most updated drug basket in the world, and we have patients who are being treated with drugs that cost 1 million shekels a year, but this is a great burden on our system. Like always in many places, you can do nothing. But in the reality of the health system, there's a price to doing nothing. If we do nothing, reality happens anyway. The public responds to things. So we looked into a number of parameters, 3 parameters, a not very complicated extrapolation. What happens if we do nothing? First of all, the national expenditure will grow in any case because the population is aging and they need more services, and elderly people at the age of over 65, at 75, they use a greater proportion of the health services. So if we do nothing, that growth will continue, and we will all be paying more from our own pockets. And that will come from our own pockets. In other words, we will pay more ourselves. And the meaning of that is that the public nature of the system will be eroded and the lines will grow longer. You see here the lines for consultations, what was in 2010 and what it is today, and what it will be if we do nothing. This is, of course, a scenario that is only for the slide. This is not something that is acceptable under any terms. Unlike many systems that are in a state of crisis and don't know what to do, I don't know necessarily there's a quick fix for real estate or education or inequality in general. The health system knows what to do, and I think there's a consensus, a full consensus in the system and the Treasury. It's just a question of allocating resources. We know what needs to be done, and the system is excellent and the most effective in the world. And with more resources, it will produce the solution that we are looking for. We must maintain this public attention to health in order to succeed with that. Now we have entered a very challenging period in terms of the economy. Perhaps it's not my job, I'm an official, to say that there won't be a solution if we don't raise taxes. We have business people and employers here who ultimately end up paying the salary costs, but we can only have a change if there is a change in priorities in the national budget. That is a short-term, poor solution, and the system must assure its own resources, and the only way to do that is to raise the health tax. It's almost the lowest in the world. Maybe in Mexico it's lower, and the combination between that and the public expenditure. And we also did surveys to see what the public said. The public is willing to pay. If we don't pay it publicly, we'll pay it privately. The expenses will go up any way you look at it. And if it goes publicly, we can manage it. We can tell the public what we're going to do with the money, and as we see it, that's a structured process that is very closely related to the solution. We can't just talk about problems without talking about the solutions, even if they're unpopular. So what do we do at a conference where we have a lot of military people in the past and the future? We need a multi-year plan for health that will have a number of different components. First of all, we need to deal with the health basket. There are a number of concepts that may sound cynical, and I'll try to simplify them as much as possible. The expenses in the health basket cannot continue going up, whether it's because of prices or demographics, without compensating for it. We cannot erode the excellence of the Israeli health basket if the health basket is not given the constant injection of added technologies, and so that Israelis will get the best treatment possible. The system will not be able to withstand that. We have to look out for the public hospitals. We have to make sure that all of the hospitals in Israel that do not belong to an HMO or the government are in a state of collapse, close to bankruptcy. We have to do root canal treatment for these problems, and we have to find the balance between the community medicine, and Israel has excellent community medicine, and things come at the expense of one another, but under the threshold of 1,000 of a bed for every 1,000 people, we cannot go below that, and we must add at least 350 beds per year. And also there's a matter of an intervention program. It doesn't involve a huge amount of money, but a few hundred millions that can make a huge difference. Shuki spoke about infections. Those infections that we have targeted with intervention, we have managed to kill 50% in the neonates ICUs and so on, and in Sheba hospital, and you can see results without a great deal of money. And also in the ERs, we had one of the hardest winters we've ever had, but still we have managed to see a welcome reduction in the number of people coming to the ERs, and we want to continue that trend. We've also improved the treatment in the neonatal ICUs, and we can produce results with the money. What will the public get? We're not just saying, give us the money and we'll manage. We are fully accountable to the public. The first thing we are saying, and indeed Professor Shemer is absolutely right, and others too, the matter of people in the hallways of hospitals is something that should be stopped completely. We have finished our work with the Treasury and others, and we say there in that report, in real terms that within 5 years we will make sure that there will no longer be anyone lying in beds in hospital corridors. That is one of the most important things with everything that Israel has done in its 71 years. When it reaches its 75th birthday or 76th birthday, it's something we can do as a national project. It costs money, but we know how to do it. We make other promises, but they're realistic. We don't believe that it's logical to wait more than 4 hours in an ER. There may be some people that will have to wait longer, but this is a target we believe that is doable, and we do not believe that people should have to wait more than 2 weeks to see a doctor, a consultant, a specialist. And we will do it, and we can do it, and we're talking about hospitalization at home, in the community, and shortening the waiting times. I'd like to talk about things that have happened in the health system in recent years. Health has also become an opportunity for economic growth, and for that I would need more than 15 minutes, but indeed the excellence of the Israeli health system has created a huge opportunity. We see interest from all over the world, people coming to see how the Israeli system is structured, and that develops a lot of industries, the concept of AI and deep learning and machine learning and so on and so forth, and all of this has very significant and positive implications. You heard here earlier from the head of the Mossad who spoke about Iran, and you spoke about and heard about national resilience. We are optimistic about our ability to contend with the existential threat posed to the health system, and it is an existential threat, no less than the other ones that have been discussed and will be discussed at this conference. A health system that is not functional will cause a society to deteriorate. Apropos the termites, and we believe in social solidarity in Israel. It will be terrible if we don't do this, but on the other hand, it is doable, and there are many problems that the state doesn't know how to resolve, but this problem we can solve. We need the public discourse here and in other places in order to indeed address this problem, and I'm sure you all wish us the best of luck. Thank you.
Thank you very much, Director General of the Health Ministry. We heard about many directions and intentions, and we're going to wish success. We hope that everything that you put out there will materialize for the benefit of the public, for the benefit of all people in Israel. And now I'd like to call the journalist and political commentator, Mr. Shimon Shiffer, who will share a personal story with us.
$15.
15 minutes. Thank you very much.
Schiffer
of blessed memory, my wife and friend, for 44 years, died Thursday, February 8th, 2018, at home, our home in Tel Aviv. For 9 months, from the moment we learned that she has liver cancer, she fought the disease. She believed that she had several more years. If there is one single memory that accompanies me since then, it has to do with the fact that she never received any compassion from the system that was supposed to provide worthy health and medical treatment, particularly the treatment and the way the doctors and others should have treated her. When we learned of her illness, we managed to launch a book that she wrote about serving for 10 years' time as the director of the test department. It's called Of All Respects, an all test. This expresses her personality and integrity. She is a woman of mercy, one of the first notices that we received after she died was a text announcement where, of course, they showed compassion and condolences, and it said, "We will never forget what Rachela did for our daughter." At the summer 2004, when she was director of the test department in the Ministry of Education, a day before the matriculation exam, a mother of a student came to a family physician, and that doctor said that she is sick with cancer and it's terminal. The mother went home and she hung herself a day before the matriculation exams began. Because the mother was married to a very famous journalist, phone calls started reaching even me. We're looking for Rachela. Rachela needs to make a decision. I called her and she said, "You can tell your friends that we don't need any connection here. I already made up my mind. I decided to give her a full matriculation diploma after I heard the story. You don't need any connections here." When we were hospitalized, we didn't look for any special treatment. One of the first decisions was that we're not looking for any connections. We didn't let anybody know. The second decision is we're not going to hide the fact that we are ill with cancer. And the third decision is we have our faith in the system. And this is how we started rolling from the first hospital, Ichilov Hospital. And we started receiving a treatment with a certain medicine. After the beginning of treatment, we met the doctor that was supposed to be treating Rachela. The meeting took place for 7 minutes. It opened by the fact that the doctor was very busy typing all the information of the appointment. While she was typing on her computer, she said, "It's over. There's nothing for me to offer you." And she continues typing. And my wife is asking her, "So you are suggesting that I'll start counting back?" She continues typing. She is not looking in her eyes. And she says, "Well, out there I have my research assistant waiting. You can meet with her and she will look to see if you can fit her research group." It is so ironical that this morning in a very famous newspaper I read about this doctor. She is the leader of researchers. This year she held most researches. We left her office and I decided through these 7 minutes that we will not be staying at this hospital because I knew the situation of Rachela, but I'm not going to stay there. This is no way to treat a patient, no compassion. We left, and this research assistant was asking my wife all sorts of questions. Only after Rachela died, when we deciphered when we looked into the texts that she sent to her friends back and forth, after these months I learned that she is writing to her friends, "How can they let go of me so easily? That's the way they're doing this. They're going to let go of me so easily." I saw this text going throughout her friends. Unlike me, she never cried. She never cried. She never complained about her destiny. I remember that in December, when we left for the premiere of Fauda TV series, she raised her head and said, "I cannot believe that I'm going to die." And she died 3 months later. We left the hospital and we went to a different hospital, no names, but Tel Shomer. And there I knew. And I remember 3 things. I remember Nurse Maya, who to put all of these toxic materials to my wife's body. And she complimented Rachela for the perfume she was using. And when she left the room, she ran to the super farm and buy her this perfume. And I remember that we set a date for another treatment, and she died just a day before that. And no one from the hospital ever called to find out why she did not make the appointment. Several months later, on Shabbat, on Saturday, that is, the spokesperson of the hospital saw me. She said, "Hi, Shiffer, we heard that you switched to our hospital. How do you like our hospital?" And I said, "She died 3 months ago. It's the same shit. You can write it down." What amazed me most of all, and very close to Yom Kippur, I published a very big article about what we went through. I included details that seemed unimportant. For example, one of the things that you are amazed at when you are a patient at the oncological department, the oncological wards are always like the El Al branches at the end of the terminal or at the end of the floor. It's always so annoying that when you get to Munich or to Frankfurt, everyone goes in very quickly with their galabias, but we, the Israelis, have to go to the end of the world, so to speak, to the end of the terminal. When you come to Tel Shomer Hospital, one of the first things that you're exposed to is that the oncological department is at the end of the hospital. In my case, my wife, who used to be an Israeli champion in gymnastics, first of all, putting her in a wheelchair, she refused to begin with. But later on, in order to receive a wheelchair, you need to give some sort of a guarantee to put something. You cannot just come in for the most simple process. No, you have to give this guarantee, and then this is going to make sure that you're going to return the chair. In Ichilov, where my friend Professor Gamzu says that things have changed, leaving home 7 in the morning in order to make sure that we reach a chair at the oncological ward. It is so full of people, and then you sit there, the month of November, and someone approaches you and says, the people from the left are also sick. You say that we killed Rabin, so you deserve it. And you sit out there. I did not go towards my very wild understatement. What amazed me after I published my article about what we have gone through was the fact that I received hundreds of comments and reactions, and all of a sudden I was exposed to something that I was unaware of. How many people in Israel go around and feel so fragile, feel that they have been offended and hurt by the system. Just a week after the article was published, the phone at home was ringing, and I'm hearing someone crying on the other hand, because he's a very famous person. I don't want to say the name. I'll just hint that his brother is a Nobel laureate. And he says, "Shimale, your list is, and your article is about me and my wife. You know what sort of a treatment they gave us? Do you know what the doctor said to me when I tried to disagree? He said, 'Sir, your arguments hold no water. They don't even have a drop of water.' And now you go on to say, what's going on here? I have emails. A doctor wrote to me after this article became public. It's amazing. I had the same thing with the same doctor with my own mother. I said to the doctor while we were having this brief appointment, maybe I'm not such a distinguished researcher as you are, but I'm a doctor. You can explain things to me. Etgar Keret, the writer with whom I'm having coffee almost every morning nowadays, he said to me once, when he is consulting authors, people who want to write, take your eyes up, raise them from the keyboard. Don't be so invested on the keyboard. The story is not there. And I saw you cannot only stick to the keyboard and keep your eyes down there. In the first week, when we understood that Rachela is ill, this was the only week when she was hospitalized. One of the things that I would like to suggest to the health system is when you, the doctors, go into the patient room. We always have the head of department, and he's always questioning all the interns and making things so hard for them. There's a person lying there who is as intelligent as you are, as educated. In the case of Rachela Shiffer, each and every summer, 23,000 people worked under her. She decided on people's destinies, and she maintained, and she said it to all her employees, that at your work desk, you're going to have two trays. The first is what you're supposed to do, your action items, and another tray where I would like to see each and every day what you did for somebody, some good deed, some favor. Who did you take care of? And I say to you that if you work in the health system, you should teach this to your doctors. About ER or the doctors, I don't want to talk about them because I think that we have an exceptional system. There's no problem with the doctors. I can understand, particularly doctors who are working in those oncological wards. It's a horrible thing. This encounter, this meeting with the sick person, with his family members. And before I'll end, I have another minute. The announcement. How do you tell a person that they're sick? In my wife's family, a year before she was exposed to cancer, her older brother, Mordechai Chaver, he did not feel so well. He went to get tested. He went to the hospital, to the Carmel hospital. No names. And a week or 2 weeks after those tests, he didn't hear back from them. He did not hear back. He was a man in the public office, and he immediately complained to someone there at the hospital, and then a secretary called him up and said, please come tomorrow to the hospital gate. You're going to have an envelope for you there. And Captain Mordechai Chaver reached the hospital, the gate. He took the envelope. He went into his car, and he found that he has pancreatic cancer. And then we found out that he only had 7 more months to live. He called Rachela, his sister, and he said, listen, I'm sitting here in my car. That's how he learned of his condition. Since Rachela passed away, I have been going and speaking at schools of medicine. I was at the Technion, and a minute before I came up to speak, a student was acting out. What does a doctor think before a cancer patient comes into their office? The sentence that he used in his stand-up comedy, the doctor said, well, excuse me, what, am I your support group? What are you expecting? Don't you have a family? I need to give you the result, the final outcome. I'm not here to console you or to embrace you. Dear friends, this is compassion.
The Herzliya conference, this important conference, always discusses systems and strategies. It discusses big and important things, and I think Shimon restored us to the importance of ultimately looking at each and every individual and what the system ultimately needs to do. And resilience is an accumulation of a lot of experiences and stories. And Shimon, thank you for sharing your moving story with us. Thank you. And now we'll move on to a symposium, and I have the honor of calling to the stage some of the most central people and most influential people in the health system today, those who have the most impact on how the health system looks. The name of this moderated discussion is, Has Israel Given Up on Its Public Health System? Public healthcare system. I'd like to call upon Professor Shamiss, the CEO of Assuta Medical Centers, and Saar, the CEO of Maccabi Healthcare Services, and Sigal Regev-Rozenberg, the CEO of Meuhedet Health Services, and Professor Arnon Afek, the Associate Director of Sheba Medical Center, former Director General of the Ministry of Health, and Noah Hyman, the head of healthcare team budget in the budget department in the Ministry of Finance, and Ronnie Linder Gantz, a health reporter in The Marker, and she recently won a prize. These are the people, and I am also happy and proud that in this symposium there are as many women as there are men. Professor Shamiss, good afternoon. I would like to start with a question in wake of the previous presentation. Can compassion be taught? And I'm talking about the health teams. How would you do that? Perhaps very briefly, Ron. First of all, I planned to say all kinds of things, but when I heard Shimon talking, and before that, the CEO of the Ministry of Health, who presented so intelligently what is happening in the health system, I had some dissonance. I have some people here in the audience from my previous organization. I cannot ignore this dissonance. When my mother was ill, very seriously and very fragile, with many diseases, for 7 or 8 years, I didn't put her in the hospital for even one day, because it's not that the doctors don't have compassion, and the students have compassion. Those who choose this profession are compassionate, but the system has lost its compassion. And the system, which is all of us, we find it difficult because we are burnt out, because we have lost our compassion.
In order to do it, we need to teach compassion. I am involved in a hospital, and I met the entire management, the heads of wards, etc., and I said to them the following: this hospital perhaps will not be one that has centers of excellence like at Sheba Hospital, but it's going to provide the best service, and it will be with compassion. And if you don't look at the patient in the eyes, you don't embrace them or talk to their family members, you're not going to be head of the ward.
And that is the head of the department, because the head of the department is the leader. He's the one who leads all the others, and he teaches the students or the other doctors. And the nurses and the doctors and the orderlies and the nurses' aides, they must all embrace the patients. Those who come to the health system have compassion, but the system doesn't have compassion, and we have to teach the system. We have to teach students how to be compassionate and also to be role models. And being role models, residents, and the heads of the system, the heads of the department, the CEOs, they must be compassionate, and they must look people in the eye and explain, and then there'll be compassion. I think compassion is the organizational culture. It's not only in a hospital, it must be in the community too. When a doctor sees a patient, and when an elderly person is waiting in line and the nurse says, I'm going to have coffee, and not just when a drug isn't authorized or patients are sent from one end of the country to another and they can't travel and they don't have cars or money. The subject of compassion is a culture, and it is something that we have to teach. I don't think you can study it in medical school. The system must behave with compassion. It's like a value. A value isn't just a poster on the wall about values that we guide us in our behavior. It's not just posters that you find in the offices of directors and heads of department. It's the way we should behave. And compassion, if all of the heads of departments decide, then there'll be compassion, just as there is integrity and honesty and human rights and so on. And to call people who don't behave compassionately to order. But if we relate to compassionate as a value and we teach it in school, it won't happen. We have to make that change in our organizations and to be very non-indulgent and intolerant towards those who don't behave compassionately. Do you think that medical schools and nursing schools, I'm not talking about teaching compassion, but rather giving tools to contend with it? It was very difficult for me to hear what Shimon had to say, but I listened, and I promise to try to learn and see how we can improve those paces that he talked about, because it was difficult to hear it. It's very difficult when I go through the various departments. It's difficult to see an elderly person or even a young person in a corridor, lying in a corridor, and certainly not the elderly, the people who built this country. They deserve better. And I think what the CEO of the health ministry said is absolutely correct. He wrote that one of the goals of the ministry is to place the patient at the center, and I agree with that 100%. And of course, we can teach it, but more important, the teaching is educating to it. There's a big difference between teaching something and educating towards something. When you teach, you give tools, but when you educate, you give a personal example. You are a role model. You have to start from the smallest thing to treat one or two people and show our environment. And people here are indeed they work under great pressure and they need more resources. But if every single one of us takes that time to care for just a few more people properly, the effect will be great, and we will be educating the younger. It will educate them, and also it will be educating ourselves to behave that way. A few months ago, I toured one of the hospitals in Israel, and the CEO invited me to see the new building they had built, and he was very proud of the new building. And he took me to the ORs, and we saw the most advanced ORs in Israel. And I asked him, because we're in this very big discussion about the crisis in the internal medicine departments. And he said, where are the internal medicine departments? Are they also in the new building? And he said, no, we haven't yet refurbished or renovated the internal medicine departments. They're last in line. In certain places, they know how to give very good service, and the system likes to compete over its innovativeness, and every hospital and HMO wants to show that they're the newest, the best, the most creative, and sometimes the less sexy parts of the system are left behind. And I was in another hospital, and there was the matter of the internal medicine departments that were not renovated. That repeated itself again. I saw a new department, but when we got to the internal medicine again, they were the last in the line for renovations. I think the lack of compassion is the most common complaint I hear from patients. I think compassion is perhaps the most important thing alongside quality medical care. And indeed, this proposal by Shuki to call the health ministry the Ministry of Health and Compassion is a good idea, because until you set something as a target that can be measured, and you do measure it, it remains a slogan. Compassion, the patient at the center, it won't change until you, perhaps it should be measured like the fire extinguishers during the accreditation process. Maybe that sounds a little cynical, but I think that's how it is sometimes. Another issue, this conference often talks about strategy as part of the resilience of Israel and social resilience, and there is sometimes a clash between these things because things come at the expense of something else, and the Ministry of Health is fighting for prioritization, and it has to fight sometimes against the Defense Ministry, which is very highly budgeted. And we're talking about percentages, and we're always talking about the home front. The home front is our social resilience. Has the state of Israel given up on the public sector? This provocative statement, have we given up a strong health system in the periphery? So thus, for example, if we talk about the closing of the Sde Airport in New York, they talk a lot about the medical aspect, about cancer patients coming from Eilat to the center of the country. I personally think that the flight to Ben Gurion Airport is certainly not the important aspect. The important thing is that when a person comes to Yosef Tal Hospital in Eilat with pressure in the chest, there isn't someone in the Eilat hospital who can catheterize him 24/7. And that doesn't have anything to do with the airport in Tel Aviv. When Shuki mentioned the problems, the differences between the periphery and the center, has the state of Israel given up on high-quality medicine in the center of the country? In the context of the airport, nobody talked about the state of medicine in Eilat, and in this whole discussion kind of exploited the patients who will have to fly now to Ben Gurion, and they will get a better service than they got until now. There will always be people from Eilat who will have to fly to the center of the country because there are services that cannot be given in such a small city like Eilat. But what it does service is the very serious situation of the health system in Eilat, that for many, many years the system there is structured wrongly. There isn't enough cooperation between the HMOs there, although it's a very different situation from many countries in New Air. The lines are very long there. They rely on doctors coming from outside. And yesterday we discovered something that I didn't know until now, that they don't even have a helicopter 24/7 for those cases that need urgent catheterization or cardiac surgery or brain surgery or a premature baby, a preterm baby that's born, that need to be flown 24/7 to the center of the country. And I think it's indeed ironic. We found a very neglected part of the health system, and perhaps this crisis will help improve the situation. There's maybe an opportunity to reorganize the system over there. Is it dangerous to live in Eilat in that sense, in your opinion? With your permission, I think that it is dangerous to be an internal medicine patient in the center of the country. I think the anecdote of Eilat is interesting and important, and I have a lot to say on it, but it's not the main issue. We need to understand, and I go back to it again, we in our ERs and in our internal medicine departments, we give third world medicine. And that's a terrible thing. And what Ronnie said, Noah said about the beautiful buildings that are being built, that's exactly the thing. We have excellent meta centers in the Israeli medical system, alongside which there is third world medicine. That's the problem. So you can talk about the patient in the corridor and the lines in the ER, a patient who has occult blood discovered in his stool. He has to have a colonoscopy within 3 months in the community. And they can't give him an appointment within 3 months because there aren't enough machines and there aren't enough doctors and there aren't enough whatever or budget. So they've lengthened it to 4 months. A patient who has occult blood in his stool and has a suspicion of colon cancer, his situation can become terminal if he doesn't have a colonoscopy. And if he can be saved, he may suffer from a terrible quality of life because he has a stoma for the rest of his life with a bag because they didn't manage to get to him in time. And in Eilat, it's true that it's unfortunate that the situation is as it is, but this needs to be done by providing medical care all over the country. Priorities must be changed, and I've seen a lot of presentations. But what brass tacks, what actually happens is I'm not talking about the money in the health system, but there is enough money there. But the money is given after. And let me explain that. I had a discussion before I got in here with Noah. The less money, less budget is given than in 2002, systematically. There's a constant erosion, and it got worse in 2008, because we didn't look like this in 2008 vis-a-vis the OECD. We were like the OECD in 2008. And what is happening, those very gifted young men and women in the Treasury, they found this trick. They make an arrangement, sometimes at the end of the third year. Why? Because otherwise the system will collapse. And then they inject money that is not part of the budget base for the HMOs and hospitals to pay their suppliers. And that is money that's not part of the budget. It's just in order so that we can survive until the next year, until the next process. And there'll always be money missing. And that's how you starve the system. And so you have those internal medicine departments and you have the community clinics without enough, where they can't do a colonoscopy or a PET CT, you can't get an appointment and those things. And not the example of Eilat, which is indeed unfortunate. I don't say it isn't. Sigal, before you answer, let me add a question. The Ministry of Health published its financial report this morning or yesterday, and in the report there's the subject of the costs of the hospital, which is a very big component in the cost of the HMO. Some 19 billion shekels were spent in the health system in 2018 for hospitalization, where the cost of operations was very close to that, 18 point something billion. But discounts, regulatory discounts, were given to the HMOs because of the firm financial state of the HMO. So if you take the expenses and subtract the 6 billion given to the HMOs, can the hospitals continue to give service in that way, especially in the periphery? I'll get to that question, I think, at the end. I'm not worried about what Noah will say. I've been in the system for 30 years. I've been a CEO only for a few months, but I've been in the system for 30 years. And to be in a public system for 30 years is a tough mission. And I love the system. I had a very great hope in 1995 when the National Health Law was passed. I realized at that time, I said, finally, somebody understands what health is. Somebody understands that health is the basis for all the citizens of Israel. A national health law that provides high-quality health care to all citizens of the state is a very important thing. And 10 years after the law, money was injected into the system, and there was growth and expansion in the system of infrastructures for about 10 years. I said 10 years deliberately. For 10 years, we ran around like crazy, improving the system, building the system, improving everything, all those wonderful things that Israel is so proud of. I think that in the past 10 years, there isn't enough planning. Nobody is doing any long-range planning. Long-range planning is to take a stone and throw it and say, what health system do I want to see down the line? We have an excellent law, but it doesn't need to be private versus public health services. Part of the problems that Moshe Bar Siman talked when he talked about 63% versus 37% public and private, that's because people don't believe in the system. It's not because we have such a good and strong system. They don't believe in it. I have money, I'll go to a private doctor, I'll have a private MRA. If you could buy hospitalization, you can't, but they would if they could. I'm not sure that, I don't think private health care that's bought privately is better. It's probably not as good as public system. Public health system can buy more with their money, but I think you have to throw that stone very far. If you ask us if we've given up, if there isn't a very clear strategy for the system, what kind of system we want. Everybody's talking about hospitals because it's very photogenic. You know, the old lady in the corridor, what Shuki spoke about at the beginning of the first presentation, elderly people in the corridors are very photogenic, but the most problems that we have are in the community. Most of our lives are in the community, the well baby clinics, the family practitioners, our blood tests, the nurses, our children, and so on. We do that in the community. The community must improve. It has to reach the cutting edge of medicine, not third world. We're giving the same thing like 100 years ago. And there are so many new drugs and MRIs and biologic drugs and robots, but community medicine is where the change will be made, how people will look. I think that the planning, long-term planning is what is needed now. Somebody who will plan where the system is going and convince the government and the treasury, this is what you want, if you want health, come, this is what we need to do. And we'll bring in the money and we'll see where the money will come from and we'll set very clear goals and all the HMOs will go in that direction. All the 4 HMOs, they can all be excellent HMOs. We need many HMOs, at least 4 or 3, not 2, not 1, and to move ahead in that direction. And another thing that we have given up on is collaboration. We're too stagnated. We need cooperation with the Academy and the National Insurance Institute and High Tech and Strauss with food, improving food, and collaborations with kindergartens and restaurants. And there are plenty of places where we can collaborate, and I think the system is very much self-involved with its own regulation and sanctions, and it's not flexible, and more collaboration is needed. We're not living before 1948, and there are barriers in every direction. And in the end, very few people will remain in the system, and people will start building alternative systems.
I would like to add, for your sake, just a word about planning. You talked about planning. In 30 years, we're going to see an increase of 3 million, for example, apartments, who will need, I'm not saying how many hospitals will need to support it. And the question is, in light of the planning, is this issue being discussed? And by the way, the plans of the Ministry of Health that are definitely are aspiring, is this going to provide a proper answer in the upcoming 30 years, let's say? I'm going to answer your first question regarding periphery. It's okay, because we mustn't ignore it. We have to be very candid here. You cannot turn periphery to a center on the level of services that are provided in the center, because you cannot make sure that you have the same thing everywhere. Otherwise, it is not going to be a periphery. Maybe this is what we're going to see in 30 years' time, when we'll be about 18 or 20 million people. But what can we do? First of all, each and every hospital can do something. If each takes a task to assist, to support, to work together with hospitals in the periphery, we can improve on the quality of medicine. For example, we see that departments are sharing. We have doctors who are operating in other hospitals. We do the same with the Ziv hospital at Fayat. We help Doron Almog at Alen Negev, and we work together with Dr. Baum in order to promote the entire topic of answer when there is infections. And I can tell you that they're doing some things better than we do them. And I'm very happy and I'm very proud of the achievements that they bring to Nahariya. So we can do, and we can work, and we can improve the situation in the periphery. We can use other systems like telemedicine. Not everything has to be done with a physical encounter. This is one of the things that I discussed with the director of Yoseftal Hospital. We talked about what we can do to assist Yoseftal, to assist and promote and advance medicine there. As far as the issue of health, everything that was said here, everybody is right. We do need more money at the health system, but it's not only a matter of money, it's also a matter of planning and also pricing the system. It is a distortion built upon another distortion, and so on and so forth. And everyone is afraid to open this up. When Moshe came into his position, he was looking at the plan where hospitals will be disconnected from tasks. Right now, HMOs pay for me for training residents, for acting in times of emergency and teaching students. This is part of the pricing. In such a situation, private hospitals who are competing with me are way cheaper than me, but it's not true. And if we manage to disconnect the system and create a situation where hospitals, for the return of proper outputs that will be measured, they need to provide the answer for all national tasks, and we will handle with other systems at the marginal cost, then I'm sure we'll be way more efficient and citizens would want to come to us. I think we're one of the only countries in the world where the private subsidize the public. If we need to operate on a healthy 50 years old or on a sick 90 years old, it's the same pricing. It is not reasonable. Two different operations, two different situations. It doesn't make sense that they're priced the same. We have a project at Shemer Hospital. I'm very happy that Wolfson Hospital and Dr. Engela put the entire topic of the possibility of selecting a responsible doctor at their entire surgical system or layout. Why don't you allow the HMOs to select the public system? It doesn't cost money at all. And we need to implement all of these changes. So budgeting is not as important as the issue of pricing, correcting the pricing of the system and stop harming the public system because it provides services as efficient and as good as the private ones. So if you touched upon the private and public systems, and I was going to talk about it later, let's add another dimension. We talk a lot about the private system and regulation that prioritizes it as a tool for streamlining and bettering the public system. I don't know, maybe perhaps it's a secret, but private system at large is performing public work. For example, Assuta, 60% of its work is public. So everything that was talked about previously, MRI, PET-CT, and treatment of cancer, all go through the public system, many of the elective operations in Maccabi, HMO, and others. So this private system, as of 2016, the law of arrangements, I'm sure that if it hadn't been for the upcoming elections, the next law of arrangements would have been holding many creative subsections. Shouldn't we view the private system? So-called פרטי. No. You keep on adding question on question, but you get double the time, so it's fine. So I'll try to do it in half the time, she says. I'll start with the first question, which is that of resources and what happened since 2008, the gap between the public expenditure and national expenditure in Israel as the percentage of the GDP and percentages at OECD. There is a gap with the OECD, but it stems from the fact that in Israel in the past decade there was a very high increase, while OECD countries had a very low growth rate. The state of Israel increased, or the government of Israel increased the budget by 110%. This is while the entire budget grew by 55%. This means that the government decided in the last decade to give more and more for health out of the entire growth. It kept increasing, and I think that this, the controversial question that you try to elect, did the government decide to neglect the health system? I think that in the past decade, the question is absolutely not. The budget doubled itself. Expenditure is larger at the OECD, more than the OECD, while in Israel, it increased by 47%, at the OECD by 27%. And I think the main question we need to ask ourselves is, do we feel a different sort of medicine as a result of the fact that there's a very nice addition of resources to the system? In every public system, we can always talk about more money that needs to be given in order to improve the service. I think that provided the investments the government had done, we have to ask ourselves, where did the money go? Do we feel the increase in resources? I ran a test and I wanted to see what would have happened. I saw that our growth is like the average. Well, the end result is that their averages would have seemed very nice. So I don't want our national math to seem nice because we're not growing. We invested a lot. And I think that in the past decade, most of the money found itself at the cost of salaries. If doctors' salaries a decade ago was 2 times more than the average salary in the market, now it's 3 times more. The ratio of doctors to the average is the second one in the OECD average, following only Luxembourg. And if we talk about a future addition of budget, we have to see how the money goes to places where the citizen would feel it and not as addition to the salaries. Because as for the issues of private and public, I think that the government in recent years tried to do two things in parallel. They tried to limit the private expenditure. It doesn't sound intuitive to a person who is not in the health system. Why should it be like that? Maybe I'll share a short anecdote. My aunt did not feel so good and she went to a private doctor because she always wants to have the best treatment. She went to a private doctor and he said that she needs to undergo some sort of a heart surgery and he can operate the following day at Assuta. Then she decided to go for a second opinion because, after all, it's a heart surgery. So she went to the second leading doctor. She paid privately, and he also said there's something in your heart, and we have to operate on you. And it so happens that tomorrow I have a free operating room at a different place, and I can operate on you. And she took her time, and she happened to arrive at her OBGYN at the community, and he said, "You have no problem. You don't need an operation. You're just going through your menopause." And he saved her this operation. So I think this story exemplifies one of the problems of private medicine, why we have those mechanisms in the shape of HMOs that are preventing those excessive procedures, and they need to disconnect the financial connection between the doctors and patients. The plan that you hinted at actually enabled in 2017 and 18, this was enabling for the first time, enabling patients to reach public financing by the HMOs and receive private treatment at Assuta or other private hospitals. This is a highly controversial move. I think that it definitely proved itself as one that ultimately allows the citizen to receive a better service, and I do believe ultimately at the public players should lead the system because they do it in a better and more efficient manner. So you assume that a doctor working in the public system, that very same Dr. X, if they work in the public system and the private system, the indications towards operations will be different. I think that the same doctor that works in the morning at the public hospital will take the more complicated case to the public hospital and the simpler case to the private hospital, so it's difficult to compare. Ronnie.
Vis-a-vis all these accountants and these are various sites who say this, we could do this or we could do it in a different way, but we do see the facts in the field. Yes, the system is functioning and it's a very strong function, so it's not trivial that a seriously ill patient, if God forbid he's got cancer, he won't actually go bankrupt if he needs medicine. But we can already see the beginning of the way the things are gnawing away at things, and we can already see that there's a whole chain of the health system and what happens, and the queues are getting longer and longer, and we can see what's happening in the internal medicine actual wards, and we can see how the public is literally arming itself with insurance policies, private insurance policies, and more than 50% have commercial health insurance policies. Some 50%, in fact, over 50% have more than just one health policies. Can you actually choose between two doctors? Yes. In the public health, you can choose between two doctors, which is a wonderful trend, in fact. We can see that 84% in the last survey carried out by the Brookdale Institute that they need vitamin P in order to find their way in the health system. Those are warning lights that are burning bright and red for us all. In other words, we shouldn't just spend tons of money on the system and give them higher salaries, but on the other hand, they say that the Ministry of Health can work and every single public health penny spent is worth it. So if we do spend money into the system and it does show that we need more money in the system, but at the same time you need objectives proven, we need to see that the queues are shortened, we need, someone spoke about compassion that everyone is complaining about, and you spoke about a lack of planning and a lack of coordination within the system. Someone who's seriously ill finds themselves in a state of total chaos. This doctor doesn't talk to this doctor, and this hospital doesn't talk to this hospital, and you find the people running their own medical files and medical records. Not only is that a waste of money, but this is a terribly chaotic and a crisis situation for every member of the public. I would like to take the prerogative as moderator to say, although, we've got representatives of Assuta and perhaps other ones, some of the control systems about tumor boards, they exist in Assuta and other places. So this kind of supervisory actually system exists in Assuta and in Assuta that is public. So I think vis-a-vis the quality of these systems are comparable between the public and private sectors. Only the private does it in a more efficacious manner. I think that the Ministry of Finance that is trying to curb things and trying to move money from the private sector into the public sector is doing so erroneously, because they are actually just letting out a pressure valve here, because people will actually find themselves lost in the public sector, and the public sector won't be able to meet their needs. Yes, people should be allowed to buy private policies and use them, and anyone who's trying to curb the actual private sector, that is a mistake. It's a wrong direction, in my opinion. I know that that is only the minority opinion, my own, and not the majority opinion here. But alongside the shortage and the lack in planning, I think that the mortality of babies and the inequilibrium in the state of the actual debt and the actual expenditure on public expense and things that perhaps they worked 40 years ago. Unfortunately, these indices that we used at that time they're old-fashioned and obsolete. Do we want to remain in a situation that we're going to be paralyzed in wheelchairs? And do we want people with diabetes who are really going to find that their limbs are going to have to be amputated and things like that? No, we need to have other kinds of indices. We want things to be worked out in a different manner. We want indices to be changed. We want to see the streamlining kind of indices used. We want to see other things measured. How can we truly assess our health system in a proper manner? How should it be assessed? What should be the objectives that should be measured? And let us see in which direction we are headed. Because the situation at the moment, we seem to be dealing with diabetes for 20 years. Have we actually examined whether there are less amputations? No, we are dealing with the issue of tumors being treated earlier on in cancer and all sorts of other things. I'm not a doctor, so I'm not going to go into that nitty-gritty and all those problems that do exist and all the work that we work on preventive medicine and other things. I think we just simply need to measure everything. We need things to be transparent, and not only the mortality of babies and the actual national expenditure. Just for those who want to buy private health policies, let's go ahead with that. But let us at the same time simultaneously strengthen and reinforce the public health system. I don't think that the private system is an alternative, but at certain points when the doctor wants to choose that or that, that's fine, but it's not an alternative as we go on with a continuance of care from early childhood to death. No, if someone needs it for certain pinpointed issues, fine, go ahead. But the government needs to put the issues of reinforcing the public health care on the table. In Maccabi, we have various programs for the future. And we've done a plethora of things in a correct manner. I think that the public in the audience is really not from the health field, although we're now talking about health issues. This isn't a normative country. We're a sectorial country. We're one who aspires always for enhancing our security forces. We were very proud of finding in 1920 the first thief in Tel Aviv. But no, we're not a normative country. And I think that Ronnie, when he spoke about that, when he spoke about cronyism and vitamin P, yes, I think that people really do not, Shimon and those who are sitting here, you didn't really experience the health system in Israel. You're not those who really experience it, because you're as if the sort of the aristocracy of this country here in the audience. We're talking about the real people outside, politicians, personnel of the health system, and the tycoons. They don't really experience the health system. We are those who influence things. We are the influential people, but we don't truly experience it on our own flesh and blood. So, I mean, yes, we did hear various complaints about things, but had we really suffered them, we would have gone to the streets in a demonstration. I live in a system wherein I have no feeling that I am being demanded accountability. I.e., yes, all the hospitals are suffering from deficit, all the HMOs are, and the greater the deficit, more is given to you. Yes, immediately things are dealt with in the right order, that when someone bad is suffering and suddenly we find that he needs something good, etc., etc. And yes, there is a waste of money too, but if you do not feel that you are accountable as the CEO of something, then you do what is sort of the right thing for the moment, and you plan less, and you give the people who are wielding pressure on you. You don't carry out auditing as it ought to be carried out, and when there's a deficit, someone covers it for you. And I claim that we need to budget the health system in a correct manner from the very first steps. Yes, there ought to be streamlining so that they will plan properly. I don't know how to start the actual year, because I don't know what's going to happen at the end of my first year or at the end of the 3 years. So then people will say, but you didn't keep to the budget. And for those who don't keep to the budget, send them home. A public company with a board of directors, they have the stock exchange, and things work properly in the market. If they don't succeed and function properly, they are sent home, they're made redundant. So here there are excellent people, but they don't sense that accountability and they don't show it. I agree with you that a private system is important because it is the privilege of the public to choose. But why shouldn't the public be allowed to choose the actual various people in the public system as well? They should be allowed to maybe pay and give the right kind of pricing system that wouldn't discriminate the public system, so that they will be able to have a choice, but in the public health system. Then we would be able to provide much more medicine, many more procedures in the public health system. They should be released of those various cap and alpha sort of cappings and ceilings and limitations, and also retain the transparency of the system. That way we'll be able to provide a better health system to the people of Israel. And you are right, Ran, we have to ensure that it is across the board and not only to part of the actual population. So just one final round, wherein I would like to hear that the CEO of the health system, health ministry, said that he wants a health tax increased to some degree or another. But I think that this will be a certain source that will not perhaps meet all the needs in the health system. And therefore, I would like each and every one of you in your last round to relate to one or perhaps the first two things that they would do in that kind of situation. Well, I said, first of all, we do need to actually increase a health tax. without actually sort of discussing where it's going to come from. It's definitely a lacking discussion that it has not been touched upon. And we do need to invest in the actual system, and that is primary, first respondent medicine kind of thing. I think that people do experience that in their daily lives, that emergency medicine kind of thing. And that is why the whole health system is an excellent one, but we need to retain its status of the GPs. In other words, that first step, the initial treatment that they get, the HMO, the pediatric early childhood medication, and I think we need to think long term. That's an additional issue. I don't think that we invest in that sufficiently in order to prevent this kind of morbidity. I think that once and for all, we ought to have some kind of obligatory standard, so we should know exactly what the HMOs should be demanded to be given. And I think that we ought to perhaps be able to enhance what they do provide with finances. I think that also we need to invest in preventative medicine. We heard about the corrosion, the erosion, for example, of the tipot chalav, of the mother-baby clinics, and in vaccinations for babies, and the prevention of obesity and the prevention of smoking and things. And I think that that is really what is urgently needed. I think that the community now is so much, community medicine is safer and so much better. And I think that if we do so, then the hospitals will actually deal with the heroic, great, magnanimous steps that need to be taken. And I think that the community will help people be rehabilitated in the community and die in their own homes. Another thing I'd like to say is I believe in management and I believe in leadership. And it's very difficult to manage in this system. I think that because of the planning that is lacking, and instead of dealing with only finances, if I come from finance, and with health, if it's health, instead of that, I have become a juggler, keeping my head above the water the whole time, juggling, and I think that that is really terrible. And I think that, as you showed in the slide, it should be a whole percentage and not a half percentage. We have to see where we're going to draw those resources from. I think we ought to examine the prices of drugs. I think that it's reached an anomaly in the tariffs, and I'm not sure how we could compare this and which countries to compare these prices to. But we ought to take the money not for home hospitalization, but to actually build kind of clinics in the home areas. And bring those children into the system. And there's so many people who turn up. And the clinics should literally come to their houses, perhaps through televisions, perhaps through remote control, perhaps in such a way, remote kind of services, and give them the dignity they are worthy of. It could be an alternative to hospitalization, but it could be some kind of, for complex patients, some kind of community service and health provision. I would add the innovation and education into the health system, and since we're all sitting together, I think since we are here at the interdisciplinary center, we actually provide that kind of course here that would provide that. And the second issue is vis-a-vis preventive medicine. That is the most efficient and the most helpful and beneficial. I think that if we all used preventive medicine, then perhaps we'd find that most doctors will have it boring for themselves. I think that someone mentioned American the health system, which is now being, and so much that I actually was an observer during the Obamacare period on behalf of Harvard. And the first time Obama traveled to China and they dealt in national security, a very significant part was to get a loan from China for Obamacare, which reached insolvency 4 years later, by the way. But that is basically what is happening in the brave new world. But that doesn't actually really solve all the issues that we have in our own system.